Well, dear colleagues, let me introduce myself. I'm Professor Paolo Angeli from Padua, Italy. I want to thank, first of all, Professor Samuel and all the editorial staff of the Journal of Hepatology for giving me the opportunity to produce this video in order to comment our paper, How to Improve the Care of Outpatients with Cirrhosis and Ascites, a new model of care coordination by consultant hepatologists. This paper will appear in the next issue of the Journal of Hepatology. As you know, the development of ascites in patients with cirrhosis is followed by a high rate of complication, hyponatremia, renal failure, spontaneous bacterial peritonitis and other infection, and acute on chronic liver failure. As a consequence, the model of specialty caregiving for outpatients with cirrhosis and ascites is a crucial point in the management of these patients. Several years ago, we realized a new model of specialist caregiving for this patient. The most innovative aspects of this model are the following. The first, it includes a series of diagnostic facilities such as lab investigation in real time, abdominal ultrasound examination in real time, upper endoscopy in real time when needed, and others. Second, it is based on the work of an integrated team, which is coordinated by a consultant hepatologist, but which includes other professionals such as dedicated nurses, such as physician in training, such as others professional when needed. Third, it is completely shared by the primary care physician of the patients. Well, during the first month of 2011, we had the opportunity to design and to perform a controlled clinical trial, even not randomized, comparing this new model of specialty caregiving that we call it care management program with the standard one, which is based mainly on the activity of the primary care physician with the intervention of consultant hepatologist on demand. We have compared the two models in terms of 12-month survival and in terms of financial profile. We included 100 patients. 40 were followed with the new model of specialist caregiving, and 60 were followed with the standard model. There were no difference in the demographic as well as in the clinical, hemodynamic and laboratory features at baseline between the two groups of patients. Over 12 months, the mortality rate was much lower in patients who were followed with the new model of specialist caregiving than in those who were followed with the standard one. More in detail, the mortality rate over 12 months was 23.1% in the first group versus 45.7% in the second group. As a consequence, as you can see in the following slide, with the new model of specialist caregiving, the care management program, than in patients who were followed with the standard model. The difference is huge and, of course, statistically significant. Also, the probability of 30-day readmission to the hospital was much lower in patients who were followed with the new model of specialty caregiving than in those who were followed with the standard one. In detail, it was 15.4% in the first group and 42.4% in the second group. As far as the cost of the two models, as you can see in the following slide, of the new models expressed per patient's month of life was quite lower than that of the standard model. In detail, 1,500 euros versus 2,800 euros. Thus, in conclusion, our paper shows that the new model of specialty caregiving, the care management program we are proposing, improve 1 year survival in patients with cirrhosis and ascites and reduces the cost of their management. Of course, our model is not perfect. We would like to add a questionnaire on both the degree of satisfaction of our patient, the quality of life of our patient. We would like to add also a remote control at home of the patients of some very simple variables, such as body weight, body temperature, arterial pressure, heart rate, and some very simple lab variables such as serum creatinine, serum sodium, and serum potassium. But so far, the model we are proposing seems to represent a crucial point in the improvement of health care for patients with cirrhosis and ascites. Finally, let me thank all the people who made it possible to perform the study, so all my co-workers. Let me thank also Professor Bruce Rennion and Professor Daniel Schuval for their kind comments on our paper in their editorials on the Journal of Hepatology. And finally, thank you very much for your kind attention.